speaker, everybody is very familiar. Timothy Yu. Many of you already know him, and Julia also mentioned about his contribution in the N-of-1 community. For those of you who don't know, Tim is a physician scientist at Boston Children's Hospital, associate professor at Harvard Medical School. He led a groundbreaking research in autism gene discovery, neonatal care genome sequencing, and therapeutic approaches for pediatric neurogenic disorders. Together with Julia, he developed the world's first individualized drug, Milasen, and co-founded N=1 Collaborative. Our company has been working with Dr. Yu for several N-of-1 projects since 2021. I am always inspired by his passion and dedication to the field. And without further ado, he's for sure, he's my favorite rare disease warrior. So Tim.
Thank you so much, Nianwei, and it's a pleasure to join you virtually here today, especially after such a warm introduction. Thank you for all that you've done for the rare disease community too. Great. Yeah, again, thank you so much for having me. And I'm going to follow that wonderful talk with with an overview of work that we've been working on in this new era when you have really remarkable tools available to us for understanding the basis of neurologic disease and now intervening in it. And in particular, the title of my talk is going to be Progress, Challenges, and Solutions in Personalized Therapy. Now, I suspect that with Julia and Amber having preceded me, that some of these concepts I'll describe are not new, but what I hope to do is provide a little bit of an overview of a new area in therapeutic development, which is the development of therapies that might apply to as few as single individuals. And I hope to convince you through this high-level overview why this is important and necessary and not niche, as well as highlighting how far we've come, but what many challenges remain. So to set this up, of course, one has to acknowledge the current landscape of unmet needs in genetic disease, which is that even despite remarkable success defining genetic causes of conditions that afflict us, there are thousands of them. And these thousands of conditions are fragmenting the disease population into very, very small camps, such that most of these individual conditions are incredibly rare, with well less than 1,000 individuals ever identified with the condition. Often for the diseases that are my domain of expertise for neurologic diseases, these are some of the most recently discovered conditions. We're not even close to 1,000 individuals. Maybe these disease populations might number in the tens or dozens or at most hundreds. And when you then layer onto that the number of these conditions that have therapies, 500 FDA-approved therapies that might be applicable in some way, even symptomatic, if not targeted for these conditions, we've got a long way to go. Of course, this is 2024, and we are able now to envision a future when these new genetically targeted therapies that are currently on the scene are able to fulfill their promise. And it's our excitement about these technologies, many of which are still in their early phases, that leads to us the work that I'm going to be describing. But these genetically targeted therapies, gene therapies, mRNA therapies, antisense oligonucleotides, they all share in common the fact that they act via the human genetic code, either at the genomic level, the DNA level, or the transcriptome level, the RNA level. And they can be incredibly precise in which genes they target and what mutations they target, even what base they target. But that precision and that power comes at a price. These are powerful technologies, but because they are working with such specificity, they often, not always, but often require mutation-specific action. Some examples of what I mean. Well, Here are three of the most exciting examples of therapeutic revolutions in the last 5 years that we've been privileged to see. We've been privileged to see an antisense oligonucleotide developed with great success for infants with spinal muscular atrophy. And this drug, Spinraza or nusinersen, it happens to work as well as it does because it can be given to thousands of individuals because it targets an evolutionarily acquired mutation that all humans have in the SMN2 mutation, in the SMN2 gene. Other famous success stories in this space include exon skipping strategies for Duchenne's muscular dystrophy as one of the first examples of a precision genetic therapy. These are precise genetically targeted drugs that allow one to skip over mutations if you're lucky enough to have them in one of these particular exons in the Duchenne's gene. Or the most recent FDA-approved success of CRISPR editing strategies for sickle cell disease. They rely on the fact that sickle cell disease is caused by recurrent mutations that are common in the human population, allowing one targeted drug to be used for many, many individuals. The point, however, that we can see beyond these examples is that these opportunities, unfortunately, are the exception, not the rule. And by highlighting that fact, we have to confront the fact that, well, what do you do with these technologies if the mutation target for which that technology may be perfectly suited is only in a small number of individuals, not everybody? What if it's in a vanishingly small number of individuals or even just one? How do you get it developed? How do you regulate it? How do you tell if it works? That's been the problem that's been captivating us the last 5 years. And we began working in this space really because of the story of Mila, a patient who we were lucky to encounter in 2017. And Julia has already talked about her story. And our experience working to first diagnose Mila and then develop a drug for her has really led us to continue to try that strategy for more and more individuals. The theme that I'm describing, of course, is of programmable medicines, the idea that you can use these genetically targeted features of these drugs to flexibly design from some parent template, for instance, the SMA drug nusinersen, additional children drugs that from parent to child that use that same general strategy, even though they might not be exactly the same as their parents. And this type of work now has a place to live in the regulatory framework with the release of the first FDA draft guidances for this type of individualized approach. These are all released now 3 years ago. In January 2021 was the first, and then over the next 12 months, 3 more guidances. And for your reference, multiple examples of this, using this approach have now been published from ourselves, from colleagues at the Columbia Medical Center and the University of Massachusetts. And I'm not going to go into detail, but I may refer to a few of these examples. Here are examples of 4 trials that our group has run in the last 5 years. Targeting individualized therapies for CLN7 Batten disease, for ataxia telangiectasia, for KCNT1 epilepsy, and an inherited form of blindness, FLVCR1 retinitis pigmentosa. Much of this work has been done actually heavily reliant on iPS technology, as in the talk here preceding me. And actually, a significant amount of these efforts have been done with the help of Nyanwei, you and your team. This space has really grown. And the number of partners that have now moved in to work on this type of therapy is really something to see. Between the FDA and their engagement and their blessing of the space by creation of these guidelines, to the Oligonucleotide Therapeutic Society that was critical in supporting these early efforts, and produced one of the first white papers describing the prospects as well as challenges for the space. And then other groups like NIH beginning to lean in, and many academic and nonprofit colleagues in the green box. Many institutions are now working to support the development of these drugs that are for orphan conditions. I'll in particular call out, you'll hear from the N of 1 Collaborative later, from Winston Yan, the president of the N of 1C and N of 1 Collaborative, a group that Julia and I founded. I'll also call out in particular your local neighbor, the NLORM Foundation, that was a nonprofit started by the founder of Ionis, that has been really hard at work developing drugs for dozens of more additional indications, and has currently, I think, 3 of these in clinical trials right now, including this one where the investigator happens to be my boss, Wendy Chung, the new physician-in-chief at Boston Children's Hospital. So I'm going to reflect a bit on the themes of opportunities and challenges in the space. And at a high level, let's talk about the opportunities first. The opportunities for this type of new technology, or actually it's the approach more than the technology. The first and foremost one, of course, is to help patients and families. We're talking these individualized genetic technologies, by being orthogonal to standard traditional approaches that may be, say, gene targeting, these actually may provide an orthogonal approach towards addressing needs of a community that might actually allow folks who can't be served under the current gene-targeted model to be served perhaps under a mutation or individualized targeting model. And the opportunity to try to bring some hope to families of patients, especially with these conditions, which can be very severe, progressive, and fatal, is number one. A critical aspect of these opportunities that is of, I would say, equal but different importance is to learn about these children's conditions. That by definition, since we're targeting, these efforts are targeting conditions that are orphaned, meaning that they're too rare to have received significant scientific or clinical attention. These are generally occurring for diseases in which there has been no prior therapeutic attempt, certainly no successful one. And so these efforts allow us a really unique way to conduct, in a way, pilot experiments or to generate pilot experiences that tell us about whether a disease is even treatable, and how high the ceiling may be, or how high or how low the ceiling may be if a therapeutic intervention were to be applied. And they could also offer really critical information about what types of responses might be achievable. And third, in order for these opportunities to be fully realized to the maximum extent, each of these opportunities represents an opportunity to improve how we do this, how we deliver this type of care. I say that carefully because at some point there's a distinction between research and treatment and care that I'll discuss at some length later on in the challenges section. So if these are the driving opportunities, I have a longer list of challenges that I'd like to discuss. Let's start with this one. The first challenge, the first category of challenges that I like to contemplate are represented by this picture, meaning to represent uncertainties. And I'm going to try to explain this very simply. We're not always sure what we need to do. What do I mean by that? We're not always sure of the genetic mechanism or the genetic strategy which is most appropriate, because by definition, these are conditions that for which not a whole lot of attention is perhaps have been paid to in the past. Do we have to rescue splicing, as in the Milasen case? Do we have to boost expression of a gene, as in other cases that I could cite? Do we have to knock down both copies of the gene because perhaps the gene is creating an overactive, overexuberant gene, and reduction of function is going to be a benefit? Or do we have to knock down the mutant copy, right? To illustrate this a little bit more concretely, I'll give an example of a project that we've been working on the last few years. There's a condition that's caused by mutations in a gene known as MAPK8IP3. That's a mouthful. In the literature, it's also known as GIP3 from the prior biochemical and cell biological literature. This is a protein that's been studied for some 10 years, but its disease relevance was only discovered relatively recently, a few years ago, when it was found that heterozygous mutations in this gene were described in individuals who have developmental brain abnormalities. They have malformations of how the brain develops with complicated names like perisylvian polymicrogyria, cerebral atrophy, hypoplasia of the corpus callosum. So these are abnormalities in brain development, and there's also a neurodegenerative component. How this manifests in kids is with weakness and spasticity of the legs, with neurodevelopmental delay and intellectual disability, and sometimes seizures. And in the initial descriptions of this clinical syndrome, there were de novo variants reported in 13 unrelated individuals. 6 of these were missense changes, single amino acid changes. 3 of them were truncating variants, frame shift or nonsense mutations. Interestingly, 3 of the missense variants were recurrent, meaning that they had spontaneously arisen in unrelated individuals with the exact same amino acid change. And for human geneticists, perhaps not obvious to non-geneticists, but for human geneticists, this type of spectrum of mutation pattern is actually a very confusing spectrum. Typically, if you see recurrent mutations occurring where by chance any mutation could arise in this gene, but patients with this condition seem to have the same ones reappearing independently through random mutations in different pedigrees, that suggests that there may be something special about the mutation, that perhaps it's a gain-of-function mutation that has a specific impact on how the gene works. And that might suggest that this gene needs to be knocked down, either with both copies or at least the mutant copy. On the other hand, the finding that there are mutations that truncate the gene, that are nonsense mutations that simply create non-functional protein, that has the opposite implication. It suggests that it's lack of this gene's function which is critical for the disease. And that would argue that you have to increase the function of this gene to boost its expression or to replace it entirely. And this is just one example of many that I could cite that illustrates that when we take on these projects, that there's really basic biology that has to be figured out first, and such that we bear risk that has to do with the biology of the gene and the disease itself, which may not be fully nailed down. So that's an example of of an uncertainty where we're not always sure what we need to do. Another example of uncertainty is we're not always sure when we need to do it. And by this, I'm talking about interventional window. Does the intervention have to occur before birth? Does it have to occur during infancy? Can you intervene usefully in childhood, in adolescence, or later? And these are questions that often when we go into these exercises, we don't know. Perhaps there's some animal model data, but often there's not. And even if there is, it may not translate well. A really somber example of this, unfortunately, is in fact our very first case, Julia's daughter. As you heard from her, we developed an individualized medicine for her untreatable form of CLN7 Batten disease. We met her at age 6, developed the treatment. She was 6.5. We developed the treatment by around age 7.5 and launched it when she was had just turned 8. And we saw improvements in quality of life and in seizure burden. But eventually, after 3 years, she passed away. The treatment, which was working, failed to arrest the ongoing neurodegeneration in her brain. And that process, which had been preceding the initiation of treatment for some 3 years, slowed a little bit, but it didn't stop. And so it reduced her quality of life such that her family had to make very difficult decisions about her goals of care. Now, this taught us that despite this treatment working, and I should say that the bottom right panel shows that in the really generous gift of autopsy tissue that the family bequeathed upon us at the end of her life, we were able to see that the drug was working. This illustrates the point that when one goes into these efforts, one has to ask hard questions about whether or not the treatment window is still open. And the answer may vary for different diseases hugely, for neurodegenerative diseases, for neurodevelopmental diseases, even within those categories. We don't always know. Another category of challenge that we face, that's this denoted by the scale, the concept of risk-benefit. Here, all cases by definition, because when we are contemplating these types of interventions, they involve very serious conditions, all cases are, of course, urgent. But not every case is urgent in the same way. Here's an example. So here's an example provided by ataxia-telangiectasia. Ataxia-telangiectasia is a cerebellar neurodegenerative condition. It is it's a disease of progressive incoordination caused by progressive atrophy of the coordination center of the brain, at the base of the brain, the cerebellum. And the natural history of AT is such that severe symptoms don't manifest until age 5. However, we know that patients at birth already have pathology. They already have abnormalities in the way that their cerebellum has developed to a certain extent, and that those abnormalities get worse over time, even though clinical symptoms aren't immediately evident. And so this is a condition where, on one hand, there's a very, very serious consequence of the degeneration that occurs beginning at age 5. These children become wheelchair-bound by age 10, and it's typically fatal by young adulthood. But there is a period in early life where those disease processes that cause these symptoms are underway and ramping up, but the patient does not obviously look that sick. And in these instances, early intervention actually from animal data and other experience with other neurodegenerative conditions may be critical. And in fact, the top left slide shows an index case of ataxia-telangiectasia that we've talked about, where we were able to intervene shortly after birth. Here's another example of this question of timing, this question of severity. Here is a child who, with a condition called FLVCR1 associated blindness, and you've likely not heard of this, but this is a child who in infancy was born with a congenital insensitivity to pain. She had multiple injuries to her digits because she couldn't feel the harm that she was doing herself by banging on them or chewing on them or other incidental activities. She also had progressive vision loss beginning at age 2, beginning with loss of night vision, and then increasingly restricted tunnel vision. She was diagnosed with a condition called FLVCR1 blindness, and the pain insensitivity in this condition is fixed and irreversible, but the vision loss is progressive and impairing her quality of life. And considering that this is not a fatal condition, but then considering what the impact of this on this child is, in addition to her having sensory problems, she also has difficulty understanding where her joints are in space because of those same sensory neuropathies. And the combination of her deficits plus her vision changes really meant that she relied on her vision a lot for navigating the world. And even though it's not a fatal condition like ataxia-telangiectasia or like Batten disease, this required a different risk-benefit calculus to think about whether or not the ASO treatment might be offered to slow this vision loss. Not only are the severity of her symptoms critically important to consider on an individual basis, but even the risks of treatment are different for different purposes. In this case, treatment of the eye would have required intravitreal injection, or did require intravitreal injection. And there's some risk of cataract here, but it's a very different profile of risks compared to, say, intrathecal treatment for brain diseases. These sorts of considerations were discussed and with the family, with ethicists, with the FDA, and a trial was launched in August 2023. But the take-home lesson is simply that we need to consider risk and reward on an individualized basis, and we need to get used to that. It's hard to come up with one-size-fits-all rules. All right, what's this slide meant to represent? So here we have a path in the woods, a fork in the road, that leads on one side to dark and foreboding woods, and the other side to flowers and light. And that's meant to denote this concept of endpoints. And at what point in a trial are we able to draw conclusions that tell us which path we're on? When do we conclude that a quote-unquote trial is complete? Not necessarily that the treatment is complete, but that the experimental part of the trial is complete. When can we consider it complete because we believe now that it's working? Or when do we need to call it complete because we've decided, sadly, that it's not working? And these are obviously questions that are traditional clinical trial questions, but they're honed to a incredibly sharp and difficult point for small n trials. The types of signals and the type of work that is done to establish efficacy or, in larger populations simply don't work if you're talking about very small populations. And here I'll again draw upon the ataxia-telangiectasia example. This is again a condition that's marked by progressive motor incoordination and atrophy of the cerebellum. And so in this case, we chose to use serial MRI imaging as a way to look for hopefully stability of the cerebellum over time, to see whether or not we had been able to forestall shrinkage of the cerebellum over time. As an aside, it looks like it is working in that respect. But then other measures like incoordination are actually notoriously difficult to quantify. As a clinician and parents who know the AT population, you can look at a child and say, they're doing better than this child over here. But to actually put that into numbers is not a trivial thing. In this case, we had to deploy individualized and longitudinally deployable biometrics, biosensors on the wrist and ankle that could measure rates of motor movement that could give us objective and rigorous data points that we could use to convince us and hopefully others of success. All right, last couple of challenges. So this is about the misnomer of individualized medicines. And the misnomer of which I'm probably primarily guilty for having used this phrase in the beginning is that these are not just Ns of ones, but many of these therapies that are developed under this N of one paradigm will eventually be found to be applied to at least a few individuals, and occasionally many individuals. Now, again, here I'll rely on the example of ataxia-telangiectasia, this mutation-specific treatment for initially a single individual with AT. She was the only one in the world that we knew of with her particular mutation. But we later found additional children, first a second child in Europe 2 years later, and then more recently, 5 additional children in Turkey. And so what do we do when N of one becomes N of many? There are practical considerations and logistical, regulatory, and ethical considerations. At a practical level, like it's difficult to run trials on an individual basis, and then to run an individual trial in another country with another investigator, and then another trial with a different site. At a regulatory level, each of these countries may involve different structures for conducting and overseeing the trial. In some cases, like in Germany, the EMA, the European Medical Agency, is involved. In other cases, in some cases like Turkey, the Turkish regulators are involved. In some cases like Germany, they actually are not, and local hospital ethics boards oversee these. So these are considerations that are at the logistical level. Ethical considerations include if one now is expanding from an N of one to an N of many, are there additional requirements for manufacturing? Are there additional standards that ought to be met for safety testing? And additional burdens on the threshold of proof required before embarking on the larger population. I'll just point out that this is an issue that's cropped up in our splice modulating ASO trials, but it's especially an issue for knockdown ASOs, where it's pretty frequent that a single ASO might be given to larger numbers of individuals. In the J-Suffusin trial, that began with one individual with FUS ALS, but then that expanded to 11 and now is a full-fledged trial. And of course, that's a good thing to expand this to more and more individuals, but having a playbook for how to navigate this is critical. A really interesting space where this question is going to come up more and more often is for allele-specific ASOs that target a specific segment of the population that has a particular genetic marker that is the tag that ASO binds to. That the KIF1A example that I alluded to earlier is an example of that, where an initial child, Susanna, being treated, has offered hope, but also an opportunity, but also logistical requirements to expand this to other children with KIF1A, of which perhaps 5 to 10% might eventually be eligible for that type of, that same drug. My last challenge that I'll close with is illustrated in this slide. And this is the giving tree, of course, except with two protagonists, one on the left, one on the right, with different heights of ladders and different abilities to reach fruit, the low-hanging fruit. And that's to evoke this concept of equity, reimbursement, and scaling. How are these patients and these opportunities being identified? This is not a trivial thing to get a genetic diagnosis these days. And then to get a genetic diagnosis, to know the mutation, and then to know who to reach out to declare potential interest and eligibility requires having well-educated families with access to the medical technology and the clinicians who are savvy enough to connect to these research efforts. Who pays for these efforts? Is there sufficient research funding? Is there sufficient philanthropic funding? Are there commercial ways to support this type of work? Generally, the thought is no, that no one has an idea for how this could be sustained at a business level, which of course is necessary if this is going to scale. And here I don't have solutions. I just point to activity in the space to consider these questions. Editorials considering both regulatory and ethical considerations. A lot of think tanks, including our own and the N of One Collaborative, thinking about different working models under which this type of work could continue to advance. And on the diagnosis side, I will say that one tide to raise and lift many boats will be if there are ways to institute more logical, earlier, and more equitable genetic diagnosis. And here I just like to point out the newborn genome program that the UK recently launched to sequence 400,000 newborns to hopefully pave the way towards a way where it becomes much easier to identify these types of cases earlier and systematically, not just with who can manage to arrange to have genetic testing. Thank you so much. I hope this overview was interesting. And my thanks to the many folks in the community who are working hard on these problems, and to my collaborators, more direct collaborators and funders shown on this slide.
Thank you so much, Jim. Your talk is always inspiring, and yeah, as we all know, there's hundreds of challenges in front of us. Until we really dive into the detail of moving our needles, we never have a solution, right? So really appreciate all your dedication here.